Info for patient.
If the cholesteatoma is in the around the or in the oval window, because to handle the stapes in this situation is quite difficult, because when we handle the stapes in stapes surgery, it is a fixation of the foot plate. But in this situation, the stapes is a very fragile. So how you handle this difficulty?
With a lot of care.
With a lot of care.
As I said, the most difficult area you should leave till the end.
Right.
Do everything else. Do mastectomy, canal wall down, expose the facial nerve, divide the processes cochleariformis tendon, clear the mid-layer space, and leave this bit till the end. Then I generally use a very fine suction, and you can't use cotton flagellates, and so you need to have fine curved needle and very gently peel off the sac from the foot plate. I think we're talking about a situation where there is no suprastructure. Try to peel it, but you have to be extremely gentle. If you think you're likely to cause a lot of movement of the foot plate, some people propose you can leave the matrix there and don't graft the cavity. I usually try to remove the cholesteatoma from the tip. In case you dislodge the foot plate, you should put a little graft on it and plug it with a little bit of fat.
Right.
But if you remove the foot plate, at least you're sure you've removed it. But it's something which has to be avoided.
While removing the disease from the tip cells, concept in our mind that the facial nerve becomes superficial here. So what should be the proper landmark that we must avoid the injury to the facial nerve when removing the disease from the tip cells?
I think the landmark, there is a sagittal plane. As I said earlier, that the lateral semicircular canal is the most important landmark. So the vertical part runs in a sagittal plane which is deeper to the lateral. So I think it is always better to start drilling from the top, from the lateral semicircular canal, and then drill it all the way down and make it a flat kind of bed, what we call.
Right.
And drilling without that into the tip is not a safe. And if you are experienced and if you can identify the digastric ridge, that's a good landmark. But a lot of times it's not there as we see in the book. So I think the best thing is that starting from the lateral semicircular canal, as long as you know that in a sagittal plane you are superficial to that, you're safer.
Right.
You can drill all the way down to the tip. If there's a ridge, you can drill that, but you have to be comfortable with that.
Most of the time, we are not sure because it is a quite hidden area. You are working behind the sinus tympani. So what you do? You thin the metal wall, or you use any endoscope to see that area? What you do? What is your...
I think that's again the area where you leave it till the end.
Right, sir.
Take the facial ridge down as much as possible. Change the angle of your microscope and the patient. If you're doing post-oral, you have to turn the patient head towards so that you can look into the difficult corner. Once you have identified the facial nerve, the oval window, you can actually drill down the pyramidal process, because pyramidal process is the thing which is between you and the sinus tympani. So you can easily drill it down, because if you can see the facial nerve going down, the second turn and all that, you can drill down the pyramidal process and have access. Traditionally, people used to use these mirrors, because that was the time we didn't have endoscope. It's an excellent idea to use endoscope in this stage. So I think using endoscope as an adjunct to your ear surgery can be extremely useful in these situations. All hidden corners you can look around with an endoscope and clear the disease under direct.
Right, sir. Endoscope means 30-degree endoscope. 30-degree endoscope. Right, sir.
Even 0 degree gives you wider angle.
Yes, sir.
Even if you use 0 degree, it'll take you into the sinus tympani. But 30 degrees would be even better.
Regarding the myoplasty, sir, this is a very important step in mastoid surgery. Not sure that you have removed the 100% disease, the myoplasty cover later on. What is your...
Essential.
Yeah. So what is your tip to make a good myoplasty?
When you're finishing your surgery, just tell yourself that you need another half an hour.
Right.
Because that is where everybody's tired, you are tired, and you want to get away and put the pack in and go away. I do not do any mastoid without myoplasty. And this is what I've taught you guys.
Right.
It's an essential part. And you can't do a mastoid without myoplasty. The other message for beginners is that allow yourself enough time. I don't know how long you take to do mastoid. I've been doing mastoid for 30 years. I still allow myself about 3 to 4 hours to do a mastectomy, because that's where your time comes into play. If you planned it for 2 hours, you'll perhaps say get away with mastectomy and not do myoplasty. Essential.
Right.
Essential.
So there is also an online question that what are the disadvantage of white augmentation?
I think the disadvantage of white metoplasty is aesthetic.
Right.
A lot of people, some people complain, especially girls, and this is why now we talk about making small cavities, doing an end oral incision, and using a front to back approach in patients where there's a small cholesteatoma. You can have a small cavity, and then you can get away with smaller metoplasty. So
Right.
the metoplasty is proportionate to the size of your mastoid cavity that you.
So do you do post-operative audiograms in these patients?
About 3 months.
About 3 months. So my next question is, sir, what is your follow-up routine?
After surgery, I leave the packs in for about 2.5 weeks. They
Nice.
pack. After I remove the pack, I see them after 2 weeks. After 2 weeks, I see them at 3 months. And after that, usually about 4 to 6
4 to 6 months. So what is the long-term follow-up?
I think patients keep coming for years.
For years. So my second last question is, sir, suppose if we do the MRM and after 6 months patient came with discharging cavity, what is your planning?
Is
to reassess?
your patient or somebody else's patient?
Any patients. So he had MRM,
Yes.
so he has
I
discharging
think you
cavity.
have to very meticulously clean the cavity,
Right.
and make an evaluation. Is it just a discharging cavity? If it's just a discharging cavity and there is no cholesteatoma, then you can manage it in meticulous cleaning. I use silver nitrate to cauterize granulations in the cavity, and you can do 2-3 sittings after week 10 days interval. If it's no recurrent cholesteatoma, you can get good results.
Right.
But if you see there is a recurrent cholesteatoma somewhere, you have to go back and revise.
So any question from residents? We have very good opportunity. Ye Lord, yes, Shazain.
as advisable for us?
Good question. I think wherever you think you have doubt that you have not cleared the disease completely, sometime you come across very extensive cholesteatoma, which is going into different corners and oval window, sinus tympani, anterior attic. Despite all your surgical skills, you are not confident that you have completely removed the disease, then I think it's advisable not to graft it. Number one. Number two, in pediatric populations, the cholesteatomas can be very aggressive. And I've had 2-3 in my practice where I had to revise them after about 1 or 2 years because they comes out somewhere else, despite good mastoid surgery in the first place. So when I revise them, I usually don't graft them because I still have that fear that it may come back.